Morning, Diksha.
Good morning, sir. How are you, sir?
I'm fine, thank you. Thank you. Good morning. Thank you for giving time.
No, sir. My pleasure. Absolutely. Very happy to be here.
Thank you. So while we are waiting, I have just posted it on the group also, I think, or I'm about to post it, that this is for the MCH and DNB students. But recently, I have launched another similar portal for undergraduate and postgraduates. So
Yes, sir.
like Anand is managing this, so one of my other former fellows from SGPGI, Dr. Prakash Sasmal, he is managing the show there. So we already have more than 100 students joining it in the last 1 month, including some from outside India also.
That is some.
So if you have time and inclination, maybe you can give 1 or 2 talks or discuss 1 or 2 cases. The only thing we have to be careful that we will have to bring down the level of discussion for them. So sometimes it is difficult for us.
No, absolutely, sir. We can start with some basics: perioperative management, nutrition, things like
very
those.
basics, very basics. Yeah.
Yes, basics in general surgery. We can start from there. Happily, sir. More than happy to be a part of it.
We'll just wait for a couple of minutes.
Yes, sir.
Morning, Dr. Prakash. Morning. GV, you are muted. Unmute yourself.
Sir, good morning, sir.
Good morning.
Thank you. I've been regularly following every class wherever you are.
I know you have been a regular attender, but please chip in and make some comments. And as I was telling Diksha also, that since you have been involved in undergraduate and postgraduate teaching,
yes,
so
sir.
we have started a similar portal for undergraduates also.
Yes,
so you
today I saw that. Yes, sir. Today I seen
yes,
that. But,
please join that, because the students
yes,
should benefit from your vast experience of undergraduate teaching.
Sure, sir. Sure, sir. So one request, I've been following all your lectures. I'm delayed like sweet. I want any recorded of chronic pancreatitis. I've been gone through all the lectures of yours except the chronic pancreatitis. I've been in touch with Nagar, Anand Nagar. He tried a lot, but it seems it's not recorded. If happens,
Okay.
so I'd like to listen once about CP also, sir.
Okay, so we will do that. We will ask one of the. So any of the students who have joined so far, any second, third year student, please raise your hand or show yourself. Anyone?
Sir, good morning, sir.
Anand wanted to know who is Dr. G.V. Prakash. So
Good morning, Dr. Anand Nagar. I've been in touch with
yes,
you.
Sir. Yes, sir. Yes, sir. I have received a message.
Troubling you for CP.
Sir, we had one.
I request you happen to get download somewhere.
Yes. So we
like,
had one class on the CP, but on that day there was a connection problem. So the class was not recorded. So we'll try to get a clinical case, and we'll moderated by Dr. Punit sir. So, sir, we'll ask someone who is the expert.
Okay, sir. Okay, sir. Punit has done it.
I'll request either Dr. Punit Dhar or Dr. H. Ramesh or Dr. Sikora, because they are working in South, so they have much more experience. So I will request one of them.
So, but the way you put up on record, the voice, the pronunciation, that way to stress upon this is comes exactly directly to the Bhagavad Gita. It goes to my hand. So that's what I impressed when I heard about your AP. There's nothing. Again, I read 2 books. That's what all the experience which is already read. That is, you put it a correct perspective, so that where to stress, what to stress to exactly while teaching. In fact, I took class and I put up the slides, taking all the acknowledgement of your photograph, your photo of receiving award from the President of India also. So that's what
I think we can start. So today, since no student had volunteered to present a case or a topic, Dr. Anand asked me that we can do an open house session. So I thought we have discussed a lot of patients or cases with the CA pancreas periampullary, but unfortunately we don't reach up to the discussion of the operative surgery. So today it's an open house session. Any student can ask anything. Otherwise, we will start asking the students one by one. So any student, please raise your hand or put your video on. Okay, then let me ask Rohik. Rohit, can you please unmute yourself, put your video on? Which college? What course? Doesn't matter if you don't want to put your camera on, but unmute yourself, introduce yourself. Who else is there? Ajay Vane?
Hello.
Yes, good. Yeah. Please introduce yourself.
I am SR from Schemes Institute, Sora, Srinagar.
Okay. So, can you start by telling us that what do we mean by pancreaticoduodenectomy?
Pancreaticoduodenectomy is the procedure used for a pancreatic head mass or a periampullary malignancy or duodenal malignancies, or in case of traumatic surgery in which
What was the, let me interrupt you. What was the question?
it is the surgery basically removing the duodenum and the pancreas.
Yeah, so please, again, a very general suggestion and tip. Please listen to the question carefully. Give a pause of a couple of seconds. Think as to what the, I didn't ask you the indications. I asked you what do we understand or what is pancreaticoduodenectomy. So start again.
Pancreaticoduodenectomy is the procedure in which there is the removal of the duodenum, pancreatic head and neck and the distal part of the common bile duct. And reconstruction which is done by the pancreaticojejunostomy, hepaticojejunostomy and the gastrojejunostomy or duodenojejunostomy.
So it's a complex multi-visceral procedure. We have to understand that. And as soon as you say that, it also means that like any other multi-visceral resection, see, normally we take PD as a simple or a single operation, but actually it is not so. It is a multi-visceral resection with multiple anastomosis, and that is why the morbidity of PD continues to remain high, although salvage from morbidity has improved. That is why the mortality has come down in various centers. But morbidity in various reports, even in large volume centers, continues to remain high. And the reason is that it is a multi-visceral resection with multiple anastomosis. Okay?
Yeah.
Yeah. So what are the variants, you know?
Classical Whipple's procedure.
Mm-hmm.
Then pylorus preserving pancreaticoduodenectomy.
Mm-hmm.
Two variants, I know that.
Any other?
No.
SR Yadav? Please unmute yourself, introduce yourself. Parikshit wants to say something. Parikshit, you have unmuted yourself. Yes, come in. Any other variant? Any other student knows? Any student? Any final year student? Recently described by Japanese. So pylorus resecting, PRPD, that is because it was presumed or it was observed that the pylorus preserving pancreaticoduodenectomy was associated with a higher incidence of a delayed gastric emptying, and that was supposed to be or thought to be because of the intact pylorus in PPPD. So they devised this pylorus resecting, where the pylorus is divided. It's not as extensive a gastric resection as in classical Whipple's. Just proximal to the pyloric ring, the stomach is divided. So pylorus resecting pancreaticoduodenectomy, which is supposed to have decreased incidence of delayed gastric emptying. Vinay wants to add something.
As sir rightly said, that PRPD versus PPPD. So initial studies are in favor of PRPD in terms of delayed gastric emptying. But in 2021, there is a RCT published which is showing that there is no difference in delayed gastric emptying in between PRPD and PPPD. And right now there is a ongoing RCTs that is named as PyloRap, and its results is going to be published soon. and then might be we will get further data regarding whether it is that RCT is actual having data or something, some additional data will be added on this study.
Diksha, you want to add anything?
Yes, I actually wanted to ask, I think Dr. S.R. Yadav was answering our series of questions. So, Dr. Yadav, why do you think that we needed all these modifications in a pancreatic duodenectomy? What outcomes were we trying to achieve here?
So what is the philosophy behind these modifications? S.R. Yadav, come in. The students, I have said this earlier also, you have to come forward. If you don't speak now, you will not be able to speak in the exam, and it is better to give a wrong answer here than in the exam. So if you give a wrong answer here, we will correct you. If you give a wrong answer in the exam, then you will get negative marks. So these sessions are for you. So you, all of you, in fact, I would expect more hands to be raised, and then we have to choose one. Any other student? Parikshit, you want to come in? Your mic is unmuted. Sejal?
Dr. Parikshit? Dr. Ajay had answered us before, if he is willing to unmute.
Ajay, you want to add on to your answer? What Dr. Diksha is asking, why these modifications are required? What is the intent behind these?
So I think for this benefit of time and discussion, we can go ahead and discuss.
No, you can briefly kind of tell them.
Yes. So, like Sir said, that no matter what, how much progress we've made in the last 2 or 3 decades when it comes to pancreatic surgery, it still remains a multivisceral resection and a highly morbid resection. So if we look at the data and if we look at our own clinical experience, delayed gastric emptying is one of the things that makes a lot of impact in the short term, and the nutritional deficiencies and the change in physiology and the digestive system of the patient makes a lot of difference in the long run. So the two things that researchers, authors have tried to address is to decrease the morbidity profile following the surgery, decrease the delayed gastric emptying, and to see if there is any nutritional benefit, or in terms of oncological, if there is an oncological benefit in resecting more or resecting less. So these are the reasons why so many modifications have been described. Now, like it's been mentioned before, that the benefit of delayed gastric emptying has not been established so far. So there are reasons why these studies have not shown benefits. The 3 most important reasons are that the sample size has been on the lower side for most randomized control trials. The methodology of the studies has been very variable. And if we look at the timeline in which the studies have occurred, the definitions of various complications have changed over a period of time. So what you would define as gastric emptying or a pancreatic fistula in 11-12 has changed after the new ISGPS classification in 16. So these things make a lot of difference when you're looking at data and when you are interpreting the results of a study. So like Dr. pointed out correctly, that delayed gastric emptying so far has not been proven to have improved with a pylorus resecting or a pylorus preserving pancreatoduodenectomy. So we must understand the outcome that we are trying to improve over here.
Okay, Harish Dubey, can you tell us the indications for PD? Harish Dubey. Yes, please.
Hello, good morning, sir.
Morning.
Indication of pancreatoduodenectomy are ampullary tumors, distal cholangiocarcinoma, duodenal adenocarcinoma, any pancreatic head mass in chronic pancreatitis.
Carry on.
In case of severe trauma to the duodenum or pancreatic head.
So would you like to
Dr. Harish,
organize?
you must mention.
Yeah, Diksha, please carry on. Yeah.
Thank you, sir. Dr. Harish must mention before saying and any head mass and chronic pancreatitis, you must explicitly. You mentioned periampullary, lower end CBD, you mentioned duodenal, but you did not say pancreatic head cancers. Again, when you're talking about mass forming chronic pancreatitis, not all head masses require a pancreatoduodenectomy.
Yes. Yes, ma'am.
So would you like to organize your answer in a better way? Would you like to reframe the answer?
Yes, sir.
You could say it could be neoplastic conditions where it could be malignant, or it could be benign with a pre-malignant potential. It could be non-neoplastic conditions, which could be inflammatory, which could be traumatic. Okay.
Yes.
So in malignancy, as Dr. Diksha pointed out, that yes, you mentioned periampullary. You started with ampullary, lower end cholangiocarcinoma, duodenal. So they are all grouped together as periampullary cancers. What are periampullary cancers? Periampullary cancers are cancers around the ampulla. And what is ampulla? Ampulla is the common channel, which is little dilated as compared to the ducts of the lower end of the common bile duct and the terminal part of the pancreatic duct. So tumor in the ampulla and around the ampulla, which could be a lower end cholangiocarcinoma, which could be a papillary carcinoma, which could be a peripapillary duodenal carcinoma, which also could be a small pancreatic cancer around the ampulla, but within some texts say 1 centimeter, some texts say 2 centimeters of the diameter of the ampulla. So these are periampullary tumors. Then you have the carcinoma of the head of the pancreas.
Yes, sir.
That also you have to mention. And then you have other neoplastic conditions like, what are the other neoplasms other than these for which PD may be done? Yes, Harish? What are the other pancreatic tumors?
Neuroendocrine tumor of pancreas.
Neuroendocrine tumor. And what else? Another group of tumors which are not solid.
Any cystic lesion present in the head of the pancreas.
Sorry?
Cystic neoplasm present in the head of the
So
pancreas.
cystic neoplasm. So these are the other group of neoplastic lesions for which pancreaticoduodenectomy may be required. Not all cystic neoplasms require surgical resection, but that is a separate topic in itself. But at least you should mention the neuroendocrine tumors and the cystic neoplasms. Then we come to the inflammatory, of which the commonest is chronic pancreatitis in this setting. So as Dr. Diksha said, that chronic pancreatitis, which is mass forming. So there is a mass in the head of the pancreas. If you have a suspicion of malignancy, then it becomes an indication for pancreaticoduodenectomy. And in some reports, even for chronic pancreatitis itself, pancreaticoduodenectomy has been done and is making mention as one of the modalities of treatment. It's not the commonest procedure done for chronic pancreatitis, but it is also one of the modalities of treatment. And then severe pancreaticoduodenal trauma, that could be an indication, isn't it?
Yes, sir.
Any other where the disease is not in the pancreas or the duodenum primarily? Not very commonly performed, but as an MCH student, you should be aware. Are there reports of pancreaticoduodenectomy where the primary disease is not in the pancreas or duodenum, but they are involved?
Hello, sir.
Yes.
Yes.
Sir, as a part of the extended cholecystectomy.
Yeah, so in tumors of adjacent organs, not only gallbladder, sometimes
Yes.
even colon, kidney, there are reports. So any primary tumor of an adjacent organ which has infiltrated the duodenum and pancreas, where in order to achieve an R0 resection, a pancreaticoduodenectomy is required. There are reports. It's a very debatable thing. that whether it can or should be done, because what is the outcome, but it is a procedure which has been described. So pancreaticoduodenectomy this is known as combined resection of adjacent organs, CRAO. So it could be with extended coli, it could be with a major hepatectomy when it is called HPD, it could be with radical nephrectomy, it could be with colectomy, it could be with distal gastrectomy for a CA stomach which is infiltrating the pancreas. Okay. Anything we have missed, Anand? Sorry? Nobody used to do it.
Sometimes
yes.
these are indication for uncorrectable bleed from the papilla or ampulla. Maybe some post ERT complications.
Very
rarely,
rare.
but one of case we have operated in my institution.
Mm.
The bleed from the remote control, and that the endoscope is placed 3-4 stands, but still was bleeding from the papilla. We have to do the PD.
Yeah, so there could be their indications. For example, I remember Dr. Shastri in 1 or 2 meetings has presented a very severe corrosive injury of the duodenum, which required PD. There are reports where a large choledococele may require PD because it is not amenable to any other treatment. So these are rare indications. Okay, let's move on. So how do you prepare a patient for PD? Arun Kumar? Arun, are you there? Shubhankar? Dr. Anand is noting down all these names who are not responding. Shubhankar? See, this is not a primary school class, na, where the teacher says stand on the stool or yeah, Shubhankar, please come in.
So first we have to diagnose the cause or the etiology of the disease.
Okay, let us talk of a periampullary cancer. So indication is periampullary cancer. How do you prepare the patient? Let us be a little more specific.
So first, sir, we have to rehabilitate the patient for this because this is a major surgical procedure. So we have to prepare the patient for the major surgical event. So we have to check whether there is a high bilirubin present or not. And we have to check patient nutritional status, patient's associated comorbidities, and along with patients and bystanders counsel regarding complications and the treatment options.
So you started first, before I interrupted you, with diagnosis. So periampullary cancer, how do you establish the diagnosis?
So from clinical, radiological, and biochemical and endoscopic investigations. So clinical from the history and physical examination.
Okay, let me ask a direct question. Do you insist on a tissue diagnosis of malignancy?
So it is not mandatory. If it is a periampullary, if it is accessible through endoscopy, like side-viewing endoscopy, then we can get a biopsy. Otherwise, we can proceed with the radiological findings.
So which of the periampullary cancers will be seen on side-viewing endoscopy, so that you can take a biopsy?
So any ampullary growth or
what is
any...
I just defined what is ampulla.
Ampulla is the common channel of distal
so do you see the common channel on side-viewing endoscopy?
No, sir. Only the major duodenal papilla you can see.
So papilla. See, unfortunately, a lot of texts also don't differentiate between papilla and ampulla, but they are two different structures. What you see on side-viewing endoscopy is the papilla.
Papilla, yes, sir.
It is the papillary growth which will be seen on side-viewing endoscopy. Which other growth can be seen?
So duodenal growth we can see.
So if the tumor is around the papilla but on the medial wall of duodenum, which also is considered as a periampullary, that also will be seen. But a true ampullary growth and a lower end cholangiocarcinoma will not be seen on side-viewing endoscopy. Ampullary growth may be seen if you do a pre-cut. Suppose you do a pre-cut, then you may see it. But before the pre-cut, it will not be seen. Okay. So suppose you do a side viewing endoscopy, you don't see any growth, but all the radiological picture is suggestive of malignancy. Both the ducts are dilated till the lower end, till their end. So is there any other method that you can get a tissue diagnosis?
And if we are planning to get a tissue diagnosis, we can consider for endoscopic ultrasound guided by.
So the dictum, yeah, you're right. The dictum is that although it is not mandatory to have a tissue diagnosis before you go ahead with a pancreatic duodenectomy, but you should make all possible attempts. Now, all possible means depending on the availability, depending on the expertise, depending on logistics, depending on cost. So it will vary from center to center. But these are the methods by which you can try to get a tissue diagnosis. Okay. What is the biggest advantage of endoscopic ultrasound? What is it very useful for? Which side viewing endoscopy cannot tell you. Okay, let me put it the other way. Suppose you don't see a tumor on side viewing endoscopy. What is it that you are worried about? That otherwise you should say that it is malignant. What is it which can mimic malignancy and you can have a similar picture?
So in case of CCP with head mass, can
yeah, but that you will see on imaging. So endoscopic ultrasound is a very useful investigation to differentiate between an impacted stone and a tumor. And that is what you are worried about. So that is why you say that if it is available, you try to do an endoscopic ultrasound. But if you are pretty sure on radiology, then most groups would not go ahead with an endoscopic ultrasound in every case. So it is only when you have a doubt. The other reason for doing an endoscopic ultrasound will be if you are dealing with a cystic neoplasm, where you want to do endoscopic ultrasound guided aspiration of the fluid and further examination of the fluid to decide the type of cystic neoplasm, because that is very important to decide whether it can be observed or it should be operated. Diksha, you want to add anything on tissue diagnosis?
Yes, I wanted to ask, I think Shubhankar was answering. So
Yes.
what maneuvers can you do to increase the yield of a tissue diagnosis? When your endoscopist is performing a procedure for you, what all things can you ask them to do?
Yes, Shubhankar.
Sorry, ma'am, I am not aware.
Okay, anybody else wants to take up the question? Harish? Dr. Harish, Dr. Utkarsh?
Ma'am, Roj, rapid on-site evaluation.
Can you describe that a little more?
A resident from the pathology will be there, and he or she will be evaluating the slides on the site, and the cellularity is adequate or not. The resident will decide, and then we will stop the procedure.
Yes, so it's an ultrasound, endoscopic ultrasound guided procedure. You try and get the tissue specimen from the most doubtful area. Along with the biopsy, you perform a cytology. The smears for cytology are handed over to an on-site pathologist who will examine them right away and let us know whether the sample is a representative sample or not. From the same place, a biopsy will be taken. So you call that an FNB. So it's a fine needle biopsy instead of an aspiration. And that gives you a histological picture of what kind of tumor we are dealing with. This is important.
Yeah, please carry on.
This is important to know, especially when you're trying to get a biopsy from a pancreatic head tumor or a pancreatic head mass in the background of chronic pancreatitis. So it's important to be aware of these things. You were saying something, sir?
Yeah, so the other lesion which will be seen on side viewing endoscopy is a large head malignancy which has infiltrated the duodenum, involved the mucosa. So that also will be seen. But in those cases, the imaging would have shown that there is a tumor in the head of the pancreas. If I remember correctly, I think FISH, fluorescent in situ hybridization on the FNA aspirate has also been used to detect malignancy. So who was answering the preparation? Shubhankar was answering. So can you tell us a little more about prehabilitation? What do you mean by prehabilitation? You did mention some things.
So prehabilitation means the increased well-being of the patient for before a major surgery.
So tell us specific things which are done as a part of prehabilitation. What all instructions, what all steps you do?
So in the form of prehabilitation, first is the nutrition of the patient, nutritional analysis, assessment and supplementation. Second is the patient performance status, improving the patient performance status. Third is the control or assessment and control of the comorbid conditions.
So you see, as I say again and again, when you are answering questions in a clinical exam, your answers should be more practical and what actually you would do in clinical practice rather than theoretical. So if I were you, I would say, I will advise the patient to take high calorie, high protein diet. I'll put the patient on supplements of vitamins and minerals. I will ask the patient to stop smoking if he does so. I will check about hormone replacement therapy or oral contraceptive pills. I will ask the patient to continue or start doing some walking exercise. So all these things, what actually you should be doing in the OPD when you first see the patient and give him a date for a PD after 2 weeks or 4 weeks, that is what you should be doing. And you should spirometry, yes, incentive spirometry. So all these things you should be very specific. What the answer you gave, if an undergraduate or even an MS student gives me, I will be happy and satisfied. But at your level, we want specific practical, especially in the clinical examination. Okay. So you did mention about the bilirubin. Diksha, you want to say something?
Yes, sir. I was going to ask Dr. Shubhankar. So which patients being planned for a pancreatic urinectomy give you actually time to execute a prehabilitation program? Look, if you can give me 2 category of patients in whom you can actually execute a proper prehabilitation program, that would be great.
Madam, if the patient bilirubin is not too much high,
okay,
and patient is also waiting for surgery, so by that time we can rehabilitate the patient for a major surgery.
New adjuvant therapy, they give you time for a proper prehabilitation program, and patients who require a biliary drainage procedure, because you will wait for at least 3 to 4 weeks before planning surgery in patients who undergo a biliary drainage procedure. So you can advise them dietary changes, exercise, and deep breathing exercises, spirometer, which are likely to be increase compliance for the patients and have a relevant change in the post-operative outcomes.
Actually, this is something which I will request all students, that because you people see the patient the first time, the moment you see a patient who is a possible prospective candidate for PD in the first visit, because invariably in most hospitals there will be a gap of a few days or a couple of weeks. All these things you should advise on the first day itself. Okay, so 2 issues which came up during discussion: preoperative biliary drainage. Sudeep Regmi. Indications for preoperative biliary drainage before pancreaticoduodenectomy. Sudeep. Who else is there? Isha, you want to come in? Okay, any other student? Don't. Yeah, okay, come.
If significant Utkarsh here, sir.
Okay, yes, carry on.
If
Yes.
the patient is having cholangitis,
Be ready with the next question. Yes.
if the
What else?
patient is having cholangitis, if patient is having significant pruritus, and if patient is having any comorbidity or any poor nutrition, like poor nutrition is having renal insufficiency, coagulopathy, that has to be improved preoperatively. And if the resection is delayed, told sir, and if in a case of CA head of pancreas, where we are thinking that it's a borderline resectable pancreas, pancreatic lesion, then we have to do means biliary drainage, just to look for, give a new adjuvant treatment, sir.
Okay, so let's discuss these one by one. So you said cholangitis. So every patient who has cholangitis, you straight away go and drain?
Sir, according to Tokyo guidelines, sir, if grade B and grade C is there, then we will go ahead. If grade A is there,
Yeah, a better answer will be uncontrollable cholangitis not responding to medical management in the form of at least 24, 48, 72 hours of parenteral broad spectrum antibiotics. Isn't that a better answer than just saying cholangitis?
yes, sir.
And that is what we do, isn't it? Unless it is a patient who presents with severe cholangitis and systemic sepsis and septic shock. That may be the only exception where you don't want to wait even for 24 hours. And then maybe you can go straight away. But otherwise, it is uncontrollable cholangitis. Okay, one. Second, you said was comorbidities which require time. Sorry, you said pruritus. So why pruritus? Suppose the patient says, I have itching, the symptoms are for 2 months. So then the stenting should be done?
No, sir. We ask how much severe it is. Means if the patient is saying, I am not able to sleep, I am, and it's means sometimes it may be so severe that patient will be having suicidal intention. And if the patient is having, means if quality of life is significantly impaired, and we are not going to operate in few nearby.
Yeah, so you should add that. You should add that adjective, that if the surgery cannot be done in the next few days.
Because so you have to said in a way that if inoperable case with uncontrolled pruritus compromising his quality of life, because I don't think in some textbook these things have been written. From where did you have read all these things?
Sir, I have seen in the what is happening in our department. That's what.
Okay. So you have to say that it's our institutional protocol, not written in any book. Because I don't think so. Uncontrolled pruritus compromising the quality of life. Then you have to add these things. Inoperable cases, or we are not planning to do the surgery in those cases. Then we are subjecting those patients for the biliary drainage. Otherwise, uncontrolled pruritus is not an indication for biliary drainage right now.
Okay, sir.
Because the reason is that the moment you perform the procedure, the pruritus will be relieved. In fact, the first change which occurs after any biliary drainage, whether it is endoscopic or surgical, is in relief of pruritus. Okay. So third indication you said was
if the patient is having comorbidity.
So again, you should say that if the patient has multiple comorbidities which require a reasonable period of time for their optimization, for their investigation, and the patient has one of the other indications, softer indications, because as of today, the only two definite indications I would say are uncontrolled cholangitis and need for neoadjuvant treatment. The other are all relative indications which have to be qualified with some adjectives.
So in exam, if somebody will ask you the indication, then you have to quote only these two indications. Other are relative indications. So if the examiner will ask you further, is there any indication you can subject the patient for the biliary drainage, then you can say, sir, patient can be. Otherwise, these two are the definitive indications for the biliary drainage pre-op.
Okay, sir.
What about the bilirubin level? Suppose patient has no cholangitis, no pruritus, fit for surgery tomorrow. We don't want or we are not planning neoadjuvant treatment periampullary cancer, but bilirubin level, does it matter?
Yes, sir. At our institutions, sir, if it is bilirubin is less than 15 milligram per dl, then we will go ahead with surgery. If it is more than that, then sir, usually patient undergoes for biliary drainage.
So, again, if I were you, before you say what is your practice, first you should say, the first statement should be that it is a very debatable and controversial matter. There is no consensus on this. Different groups follow different guidelines. Most groups would not do a biliary drainage if the bilirubin is, say, less than 10 or 15. Above 20, some groups do it, but many groups do not agree with it. Also, you have to consider bilirubin along with other factors. So other factors would be coagulopathy, renal dysfunction, comorbidities, nutritional status. So bilirubin level alone is not an accepted indication for preoperative biliary drainage. But yes, agreed, different groups follow different practices. So see, at your level, it is not like an MBBS exam where a question is asked and you give one answer and you pass. It is a discussion. And in most questions, you will find there is no one definite correct answer. It is a discussion. We want to know whether you know everything and whether you can analyze that. Diksha, you want to add anything to pre-op biliary drainage?
Yes, sir. So I wanted to ask Dr. Utkarsh very categorically said a bilirubin cutoff of 15. Can you give me some scientific basis as to why groups who accept 15 as a cutoff accept 15 as a cutoff? What is the rationale behind accepting 15 as a cutoff, possible cutoff?
Ma'am, rationale behind is that the liver function will improve, ma'am. Means not in the I have not read in the context of this periapillary carcinoma, but in hilar cholangio it is said that the mitochondrial function of liver cells will improve.
You see,
so
liver
for
function.
mitochondrial, yes, sir.
Yeah, please carry on.
So for a hilar cholangiocarcinoma, that makes sense because you're going to do a liver resection, but that is not true for a pancreatoduodenectomy. So I will give you the answer to the question that I asked you. If you look at various studies that have looked at outcomes in patients who have undergone a preoperative biliary drainage procedure, most studies have excluded patients with a bilirubin of 15 and above. So what happens to them with or without a biliary drainage? That has very limited evidence in literature. So below 15, there is good evidence that an unnecessary biliary drainage increases the chances of postoperative infectious complications. That's why in patients in whom there is no cholangitis and there is no need of neoadjuvant therapy, most groups will err on the side of not doing a preoperative biliary drainage. Does that make any sense, Dr. Utkarsh?
Yeah, ma'am, I got your point, ma'am.
Yes. So the most of the literature takes 15 as a cutoff.
Okay, ma'am.
Utkarsh, the physiological basis of what Dr. Diksha asked is that patients who have high bilirubin levels, they are likely or more likely to have a coagulopathy. So in those patients, bleeding complications are more, whereas if you place a stent, these patients are more likely to have infective complications because you cause pectobilia. So that is the physiological, and you have to strike a balance between these. So if in spite of high bilirubin, the coagulation function is normal, or if it is abnormal, it responds to vitamin K administration, then you have taken care of the physiological disturbance and you don't want to unnecessarily place a stent and increase the infective complications. Now, one more thing which came up for drainage, this preoperative biliary drainage was neoadjuvant therapy. So Krishna was wanting to answer the first question. Now, Krishna, can you come in? What are the indications of neoadjuvant therapy before pancreatitis? Come. Krishna is our final year MCH student. Come.
Sir?
Yes, neoadjuvant therapy.
For borderline resectable pancreatic tumors, we will advise neoadjuvant chemotherapy.
What do you mean by borderline?
The borderline in which the SMA artery, if it is less than 180 degrees of involvement, and even quarterly between more than 180 degrees of involvement, if these are considered as borderline resectable tumors.
So these are the only two vessels which are of concern. Which other arteries and which other veins are mentioned when we define borderline resectable pancreatic cancer?
Morning.
Which vessels are mentioned when we talk of BRPC? First, answer that. No, that don't repeat what he has already said. I said which other vessels. So you don't get any marks for what he has already said. He has mentioned superior mesenteric artery and portal vein.
The exact definition of borderline resectable tumor according to the NCCN or the other guidelines. There is a table, beautiful table made in Bloomgardner. Many times we have already discussed. Who is going to answer what is the exact definition of borderline resectable pancreatic tumors?
Any student? So first we should know what are the vessels which are of importance.
Hello, Hari Prasad. Hari Prasad. Shubhankar.
Hello.
Yes,
Yes,
Shubhankar.
sir.
Yes, please come in. Good.
So, in the form artery will be, sir, SMA, and sir, CHA also.
Yes. Okay.
And
then
vein in the form of
one more artery which is mentioned when we talk of BRPC.
Sir, GDA.
GDA also is mentioned. Celiac axis also is mentioned, isn't it?
Yes.
Common hepatic artery.
That he mentioned, common hepatic, he said. And veins?
The veins, SMV portal vein.
And one more, very small vein. It is mentioned in some of the classifications.
So first jejunal vein.
First jejunal vein. Okay. So there is no one definition because different guidelines, different societies have given different definitions. But you should know that which are the important vessels in relation to, and also it is important in relation to the location of the tumor because BRPC for head pancreas is different from BRPC in body and tail of the pancreas. Okay. Yes. Diksha, you want to add anything to BRPC?
Yes, sir. IVC also for the vein.
Yeah,
NCC
definitely.
2016 adds IVC.
NCCN has included IVC also. So,
Yes.
student, you should know exactly according to the location, BRBC definition is different. For head is different, for tail is different. So you should learn this. All these NCCN and I think three different association has given the criteria for borderline resectable.
Can any of the students name the three definitions? Just give us the names.
One we have
Dr.
already told you, NCCN.
So another one is MDCC guidelines.
That MD Anderson, definitely. Very good. Third one.
So there is Alliance, there is MD Anderson, there is Japanese Pancreatic Cancer Society. And of course, there is NCCN.
So students, send me a mail, vkkapoor.india@gmail.com. I'll send you a very beautiful review article which was done by Dr. Kailash Kudia from PGI Chandigarh on BRPC. It summarizes everything very well, the definitions and the importance of BRPC. Okay, so send me a mail. Okay, then we move on to.
I would like to.
Yes, Anand.
We were discussing regarding the level of the bilirubin is the Dr. Diksha told, the cutoff level of 15. One of the nice elaboration of this, one of the study evidence regarding drop trial, that drop trial mentioned regarding this the level of the bilirubin they have taken in the study. It is the most article people use or people read this regarding the preoperative bilirubin.
So students, you should read, I think chapter 4 or 5 from Bloomgard. It's beautifully written regarding the by bilirubin. It's what would be the cutoff values pre of biliary drainage, and what is going to be the consequences of the high bilirubin. There is a beautiful chart in which cardiac, renal, as well as other multi-organ dysfunction is associated with increased bilirubin. And in last, there are two separate paragraphs for the pre-op biliary PTBD, pre-op biliary drainage in pancreatic duodenectomy and the different trials and what they have got in their results. So you should read that chapter very carefully, because in exam you will get, I think you will get 10 marks question for pre-op biliary drainage, definitely pros and cons. So the question will be divided in two parts, definitely for 4 marks for the indication and rest of the 6 marks for the pros and cons and in favor of the trials. So you should learn all those trials also.
So, sir, I just want to add one comment over here before we move on to the very initiation when Dr. Kapoor asked this question as to how will you prepare a patient pre-operatively. Dr. Shubhankar, you were answering. I think it makes a lot of sense to say that I would like to evaluate the patient for the surgery. I would like to know more about the tumor for which I'm offering surgery, and I would like to see the peri-operative investigations and workup. And then you start classifying patient comorbidities, patient's ECOG status. You look at the tumor, make sure if there is an indication whether there is a requirement of a biopsy, whether the disease is metastatic or not, you have proper imaging, you have endoscopy, side viewing-scopy, etc. Then the perioperative workup comes in terms of jaundice levels, cholangitis, pre-op optimization of nutrition, etc. So once you start classifying and labeling your answers, you've grasped the attention of the examiner.
Okay, I think we will have to have another session to discuss the operative part. But any student wants to ask any question on whatever so far we have discussed. Rajendra, you are also there. Do you want to add anything?
No, sir, it is efficiently done by Deepa.
Any student? Shubhankar, Ajay, you want to ask anything? Any supplementary question? Anything that we have missed out on so far?
No, sir. No.
But my request again to students that you have to be participating in these sessions proactively. We have started all these activities for you. So if you don't volunteer to present cases, to make presentations on operative surgery, then I don't think it will be very useful. Because at this stage, teaching has to be bilateral. In fact, it has to be more from your side than from our side. Our role is mainly moderating. It is not like undergraduate or postgraduate teaching. So please send your intentions or your plans to present whatever you want to discuss, either a case or an operative surgery, and then we will find suitable moderators. Okay. There was a question in the chat. Acha, Diksha, you already addressed that. Yes. And only thing is that the volume, when we talk of volume is not surgeon based. It is the unit or the department based, because everybody has to be tuned to the care of a patient who is undergoing a PD. So it is most publications highlight that it has to be the unit or the department or the institution experience rather than a surgeon's experience.
Whether it is the number of surgeries per year or how many numbers have been there to coin it as a high volume centers, because it is a non-malignant and controversial benign lesion when going by PDs. So it is said it will be done only by high volume centers. So that is the reason I wanted to know from you, sir.
Yeah, I think Diksha has addressed that. But yes, that point is very, very important, that if you are dealing with a case where there is a possibility that it may not be malignant, then one has to be very careful, both in terms of selection of case, counseling, consent process, and if there is any doubt, then there should be no hesitation in referring the patient, because if unfortunately there is a mortality, which it will happen, because there is no center across the globe which has reported more than 200 consecutive PDs without a mortality. So which means that even after that, a mortality can occur, and the biopsy turns out to be benign or nothing, then there will be a lot of medical legal issues. So selection, counseling, consent, and referral, these are very important when you are dealing with a possibly benign or a slow growing tumor.
But
Yes,
also,
sir.
so what you mentioned in the beginning makes a lot of sense when it comes to high volume centers, because the salvage rate after the development of a complication is higher in a high volume center. So it's not that complication any lesser, but because team is attuned to dealing with sections frequently, they'll be able to salvage the patients better.
Okay. So can we close the session? Okay.
Thank you,
Thank
sir.
you.
Sir, the UG students should register in separate portal. The finalist students or which
Yeah. Any undergraduate. I think even MS students will benefit. So they can contact Dr. Prakash Sasmal. They can just send a WhatsApp message to him, and he will add them to the group.
Yes.
And once they are added to the group, they will keep on getting the information. Like today evening, it is at the moment Saturday 5 to 6 p.m. So today evening, I am making a presentation on a very general presentation, how to pass an exam.
The same link or different link, sir?
Sorry?
Is it different link or different Zoom or same?
No, different. That's a different portal. So once the students message Dr. Sasmal, I will forward that link to you, and then you can pass it on to the students.
Yes, sir.
And you should enroll yourself for this session, because it is the most important thing going to be for all of you exam going student in next year. Sir is very humble. That's why sir is saying it's a very simple topic, but it's the most difficult one.
Yes, sir. Thank you very much,
Okay,
sir.
thank you, Diksha. Thank you very much for joining us. I look forward to your more active participation in these sessions. Whenever you are free, whenever you have time, just inform Anand, and we will let you join as a moderator. Thank you.
Thank you. Absolutely.
Okay.
Thank you.
And
Sir.
bye.
Thank you.
We will close.